Acute phase reactants, APRs, are proteins whose plasma concentrations increase, positive acute phase proteins, or decrease, negative acute phase proteins, in response to inflammation. They are typically produced by the liver in response to pro inflammatory cytokines like IL-6, IL-1, and TNF alpha. Measurement of these reactants is useful in diagnosing and monitoring inflammatory conditions, infections, and other acute and chronic diseases. Common positive acute phase reactants. 1. C-reactive protein, CRP, a widely used marker of inflammation. CRP levels rise in response to infections, autoimmune diseases, and other inflammatory conditions. 2. Erythrocyte sedimentation rate, ESR. Although not a protein, ESR is influenced by APRs like fibrinogen. It is commonly used to detect inflammation. 3. Fibrinogen plays a role in blood clotting and rises significantly during inflammation. 4. Serum amyloid A, SAA, levels increase during inflammation, especially in the case of infections. 5. Ferritin, an iron storage protein that increases during inflammation and infection. 6. Haptoglobin binds free hemoglobin released from erythrocytes. Its levels rise during inflammation. 7. Alpha-1 antitrypsin, a protease inhibitor that increases during inflammatory conditions. 8. Complement components, e.g. C3, C4. These proteins are part of the immune system and are involved in the inflammatory response. Negative acute phase reactants. 1. Albumin decreases during acute inflammation due to increased production of positive APRs. 2. Transferrin decreases as iron is sequestered during inflammation to limit microbial growth. Clinical significance. Infections. APRs are elevated in bacterial, viral, and fungal infections. Autoimmune diseases. Diseases like rheumatoid arthritis and lupus often present with elevated APRs. Cancer. Certain malignancies can cause elevations in acute phase reactants. Trauma surgery. Post-surgical and traumatic injuries can lead to elevated APRs. Testing for acute phase reactants is a useful diagnostic tool, but must be interpreted in the context of clinical findings. In rheumatology, acute phase reactants, APRs, play a critical role in both the diagnosis and management of various autoimmune and inflammatory diseases. Many rheumatologic conditions involve chronic inflammation, and APRs are often used to assess the extent of inflammation, monitor disease activity, and evaluate the effectiveness of treatments. 1. Rheumatoid arthritis, CRP, and ESR. These are the most commonly used markers to assess inflammation in RA. High levels are associated with active disease, and they are often used to monitor response to therapy. Persistently elevated levels may indicate ongoing inflammation, even if clinical symptoms are under control. Serum amyloid A, SAA. In chronic RA, elevated SAA can lead to secondary amyloidosis, a serious complication affecting the kidneys and other organs. Fibrinogen. Elevated fibrinogen levels contribute to the hypercoagulable state seen in active RA, increasing the risk of cardiovascular events. NAR2. Systemic lupus erythematosus, SLE, ESR, often elevated during flares of lupus, even when CRP levels are normal, which is somewhat unique to lupus. CRP is usually not as elevated in lupus unless there is an infection or serositis, inflammation of the serous membranes. Complement components, C3, C4. These are commonly used in lupus to assess disease activity. Low levels of C3 and C4 indicate activation of the complement system and are often associated with active disease, particularly lupus nephritis. 3. Ankylosing spondylitis, AS, and spondyloarthropathies, CRP and ESR. These are key markers in monitoring disease activity in ankylosing spondylitis and related conditions like psoriatic arthritis. However, a significant number of patients may have normal APR levels despite active disease, making clinical assessment crucial. Haptoglobin. Elevated levels can indicate ongoing inflammation and may correlate with disease severity. 4. Vasculitis, e.g. giant cell arteritis, polyarteritis nodosa, CRP and ESR. Markedly elevated levels are often seen in active vasculitis, especially in conditions like giant cell arteritis, GCA. These markers are used to monitor response to treatment, particularly glucocorticoids. Ferritin. This can be elevated in certain forms of vasculitis, such as adult-onset Still's disease or systemic juvenile idiopathic arthritis, where hyperferritinemia is a hallmark of the disease. 5. Systemic sclerosis, scleroderma, CRP, While CRP levels are typically less elevated in systemic sclerosis than in other rheumatologic diseases, a rise in CRP may indicate complications like interstitial lung disease or systemic inflammation. ESR. Often normal or mildly elevated, ESR is less useful in systemic sclerosis but can still provide information on inflammation. 6. Polymyalgia rheumatica, PMR. CRP and ESR. These markers are usually significantly elevated in PMR and are used both for diagnosis and for monitoring response to corticosteroids. Rapid normalization of CRP and ESR is expected with effective treatment. 7. Gout and crystal arthropathies, CRP and ESR. Acute gout flares are often associated with elevated CRP and ESR levels, reflecting intense local and systemic inflammation. These levels usually normalize between attacks. Clinical applications in rheumatology. Diagnosis. APRs assist in diagnosing rheumatic diseases, especially in distinguishing between active inflammation and non-inflammatory conditions. Disease activity monitoring. Regular monitoring of APRs helps in tracking disease activity and guiding treatment adjustments. For instance, in RA, a decrease in CRP and ESR levels indicates that the treatment is working. Prognosis. Persistently elevated APRs in conditions like RA are associated with a worse prognosis, including higher risks of joint damage and cardiovascular events. Infection versus disease flare. APRs help differentiate between disease flares and infections, especially in patients on immunosuppressive therapy. For instance, in SLE, a high CRP level may suggest an infection rather than a flare. Complication monitoring. In systemic conditions like RA or SLE, elevated ferritin may indicate the development of complications such as macrophage activation syndrome, MAS, or amyloidosis. In summary, acute phase reactants are indispensable tools in rheumatology, offering valuable insights into inflammation and disease activity, guiding therapeutic decisions, and aiding in the early detection of complications. However, their interpretation should always be integrated with the clinical context, as certain rheumatologic diseases can present with normal APRs despite active disease. Both ESR, erythrocyte sedimentation rate, and CRP, C-reactive protein, are important markers in the assessment of rheumatic disease activity, but each has its own strengths and limitations. The relative importance of ESR versus CRP can vary depending on the specific rheumatic condition, the clinical context, and the patient's individual characteristics. CRP, C-reactive protein, strengths. More specific and rapid. CRP is a direct measure of inflammation and reacts more quickly to changes in inflammatory activity than ESR. It rises and falls within hours in response to inflammation, making it useful for real-time assessment of disease activity. Less influenced by non-inflammatory factors, CRP levels are less affected by factors like age, anemia, and gender, which can influence ESR. Better predictor of cardiovascular risk. In patients with rheumatoid arthritis, RA, elevated CRP is a stronger predictor of cardiovascular risk compared to ESR. Better correlation with disease activity. In many rheumatic diseases like RA, CRP levels correlate better with disease activity and clinical outcomes. Limitations. Less sensitive in some conditions. CRP may be less elevated in certain conditions, such as systemic lupus erythematosus, SLE, where active disease can occur with normal or mildly elevated CRP levels unless there is an infection or serositis. ESR, erythrocyte sedimentation rate. Strengths, longer-term marker. ESR tends to reflect more prolonged inflammation, as it changes more slowly compared to CRP. It may be useful for assessing chronic disease activity. Useful in specific diseases. In certain conditions like SLE and polymyalgia rheumatica, PMR, ESR is often elevated even when CRP is not. For example, in lupus, ESR may be elevated during disease flares even when CRP remains normal, making it a more reliable marker in these cases. Widely used, ESR is often used in long-term studies of rheumatic diseases and remains a familiar marker in clinical practice. Limitations. Non-specific. ESR can be influenced by a variety of non-inflammatory factors, including age, anemia, kidney disease, and gender. This can lead to false positives or negatives in the assessment of inflammation. Slower response. ESR changes more slowly in response to inflammation compared to CRP, making it less useful for real-time monitoring of disease activity. Summary. CRP is generally considered more useful in the acute assessment of rheumatic disease activity due to its specificity, rapid response, and stronger correlation with inflammation in diseases like RA. ESR can be more helpful in chronic conditions or specific diseases like SLE and PMR, where it might be more sensitive than CRP in detecting inflammation. In clinical practice, both tests are often used together to provide a comprehensive picture of disease activity. However, CRP is often preferred for monitoring active inflammation and treatment response in diseases like RA, while ESR may be more important in certain conditions where it provides additional information not captured by CRP alone. A discrepancy between ESR, erythrocyte sedimentation rate, and CRP, C-reactive protein, in the same rheumatic patient is not uncommon and can arise due to several factors. Understanding the potential reasons for such discrepancies is important for accurate diagnosis and management. Here are some possible explanations. 1. Disease-specific responses. Systemic lupus erythematosus, SLE. In SLE, it is common to see an elevated ESR with a normal or only mildly elevated CRP, even during active disease flares. CRP levels often remain low unless there is an infection or serositis, e.g., pleuritis or pericarditis. This is thought to be due to the specific cytokine profile in SLE, where IL-6, which drives CRP production, may not be as prominently elevated as in other inflammatory conditions. Polymyalgia rheumatica, PMR, and giant cell arteritis, GCA. In these conditions, ESR is typically very high, sometimes out of proportion to CRP levels. ESR may remain elevated longer and may more accurately reflect the underlying inflammation in these diseases. 2. Timing of the inflammatory response. Acute versus chronic inflammation. CRP responds rapidly to inflammation and can rise within hours, whereas ESR is a slower marker of inflammation, reflecting more chronic inflammatory processes. In cases of acute inflammation, CRP may rise quickly, while ESR may lag behind. Resolution of inflammation. After an inflammatory flare, CRP levels tend to normalize more rapidly, whereas ESR may remain elevated for a longer period. This could result in a scenario where CRP is normal, but ESR remains high, reflecting the lingering effects of inflammation. Influence of non-inflammatory factors on ESR. Anemia. Anemia can artificially elevate ESR because red blood cells, RBCs, settle more quickly in anemic blood. This can cause a discrepancy where ESR is elevated even when CRP is normal. Age and gender. ESR naturally increases with age and tends to be higher in females, even in the absence of significant inflammation. These demographic factors can lead to a falsely elevated ESR compared to CRP. Hypergammaglobulinemia. Conditions associated with elevated immunoglobulin levels, such as multiple myeloma, can increase the ESR, leading to a discrepancy between ESR and CRP. Renal disease. Chronic kidney disease can result in elevated ESR due to changes in blood proteins and decreased erythropoiesis, while CRP may not be similarly affected. Number 4. Medication effects. Glucocorticoids. Steroids can suppress CRP more effectively than ESR. In patients on glucocorticoid therapy, CRP levels may decrease rapidly, whereas ESR may remain elevated. This can create a discrepancy between the two markers. Immunosuppressive therapy. Medications like methotrexate or biologics may lower CRP levels more significantly than ESR, especially in chronic diseases like rheumatoid arthritis, RA. 5. Infection versus autoimmune activity. Infections. In some rheumatic patients, an elevated CRP with a relatively normal ESR might indicate an underlying infection rather than an autoimmune flare. Infections tend to drive CRP levels higher, especially bacterial infections, whereas ESR may not rise as quickly. Autoimmune flares. Conversely, in conditions like SLE or PMR, autoimmune activity may lead to an elevated ESR with less pronounced CRP elevation. 6. Acute phase protein kinetics. Different mechanisms of elevation. ESR and CRP reflect different aspects of the inflammatory response. ESR is affected by plasma protein levels, including fibrinogen and immunoglobulins, which increase the aggregation of red blood cells. CRP, on the other hand, is a direct acute phase protein synthesized by the liver in response to cytokines, primarily IL-6. Therefore, the kinetics of these proteins can differ based on the nature of the inflammatory response. Clinical approach. Integrating clinical context. When there is a discrepancy between ESR and CRP, the clinical scenario should guide interpretation. For instance, in an SLE patient with an elevated ESR but normal CRP, the focus should remain on lupus activity unless there are signs of infection. Similarly, in PMR or GCA, persistently elevated ESR with lower CRP should not lead to overtreatment if the patient is clinically improving. Repeated testing. If a discrepancy persists, repeating the tests over time can help clarify the picture, as transient factors, e.g., anemia, infection, might be influencing the results. In conclusion, discrepancies between ESR and CRP can occur due to various factors related to the underlying disease, patient characteristics, and the nature of the inflammatory response. Understanding the specific context is key to appropriately interpreting these laboratory findings.
Can ESR be raised in the absence of any abnormality?
Yes, ESR, erythrocyte sedimentation rate, can be raised without any underlying pathological abnormality. Several non-inflammatory and physiological factors can lead to an elevated ESR in the absence of active disease or inflammation. Here are some common reasons. 1. Age, natural aging. ESR tends to increase with age, especially in people over 50, without necessarily indicating any underlying pathology. The normal range for ESR increases as people get older. Gender, female gender. Women generally have higher ESR levels than men, even in the absence of inflammation. Hormonal factors and differences in hematocrit levels between genders may contribute to this. 3. Anemia. Anemia of any cause, e.g., iron deficiency, chronic disease. ESR can be elevated in patients with anemia, particularly normocytic or macrocytic anemia. This is due to the reduced number of red blood cells and changes in blood viscosity, which can cause the red cells to settle more rapidly in the test tube. 4. Pregnancy, third trimester. ESR is often elevated in pregnant women, particularly during the second and third trimesters. This is due to increased fibrinogen levels and changes in plasma volume that occur during pregnancy. 5. Obesity. Increased body mass index, BMI, higher ESR values have been associated with obesity, even in the absence of other inflammatory markers. This might be related to chronic low-grade inflammation linked with excess body fat. 6. Hypergammaglobulinemia, increased immunoglobulins. Conditions associated with increased immunoglobulin levels, such as multiple myeloma, monoclonal gammopathies, or chronic infections, can elevate ESR. However, in some cases, these elevations can occur without any active inflammatory disease. 7. Macrocytosis, large red blood cells. Macrocytosis, large RBCs, which can occur due to various conditions like vitamin B12 or folate deficiency, can cause a higher ESR. 8. Chronic kidney disease, reduced kidney function. ESR can be elevated in patients with chronic kidney disease, even when there is no active inflammation. This might be related to the effects of uremia and the chronic nature of renal insufficiency. 9. Paraproteinemia, monoclonal proteins. The presence of paraproteins, e.g. in multiple myeloma or Waldenström's macroglobulinemia, can increase ESR due to the effects of abnormal proteins on blood viscosity and RBC aggregation. 10. Medications. Oral contraceptives. Use of oral contraceptives can cause mild elevations in ESR due to hormonal influences on the blood and liver protein synthesis. Statins. Some statins have been associated with increased ESR levels, though this effect is generally mild. 11. Post-surgery or trauma. Healing phase. ESR may remain elevated for weeks after surgery or trauma, even after the acute phase of inflammation has resolved. This reflects ongoing tissue repair and recovery rather than active inflammation. 12. Thyroid disease. Hypothyroidism. In some cases, hypothyroidism can be associated with a mild increase in ESR, possibly related to altered metabolism and changes in blood proteins. Clinical significance. While an elevated ESR can be a marker of inflammation or disease, it is a non-specific test, and an isolated elevation without clinical symptoms may not necessarily indicate a serious problem. When interpreting an elevated ESR, it is crucial to consider the patient's overall health, history, and other laboratory findings. In cases where ESR is elevated without any apparent cause, the clinician may decide to monitor the patient over time or look for other signs of disease before pursuing more invasive diagnostic tests. Persistently raised ESR, erythrocyte sedimentation rate, in the absence of identifiable inflammatory, autoimmune, malignant, or metabolic diseases can be challenging to interpret. In such cases, the significance of the elevated ESR may vary, but there are several possible considerations. 1. Benign or idiopathic elevation. In some individuals, a persistently elevated ESR may be benign and have no clinical significance. This is often referred to as idiopathic ESR elevation. After thorough evaluation to rule out significant underlying conditions, some people may simply have a higher baseline ESR due to non-pathological reasons, e.g. age, gender, or mild anemia, with no further consequences. 2. Chronic low-grade inflammation. Subclinical inflammation. Even if no specific inflammatory disease is identified, persistently elevated ESR could indicate ongoing low-grade inflammation that is not picked up by routine testing. This could be due to factors like chronic infections, e.g., periodontal disease, mild chronic sinusitis, mild degenerative joint disease, or even chronic exposure to environmental toxins. Although these might not present as overt disease, they can cause a persistent mild inflammatory response. 3. Lifestyle and environmental factors. Obesity. Chronic low-grade inflammation associated with obesity can lead to persistently elevated ESR. This is mediated by increased production of pro-inflammatory cytokines by adipose tissue, even in the absence of overt disease. Smoking. Smoking is associated with chronic inflammation and can contribute to elevated ESR, even in the absence of other systemic diseases. Sedentary lifestyle. A lack of physical activity has been linked to increased levels of inflammatory markers, including ESR. Regular exercise tends to reduce systemic inflammation. 4. Genetic factors. Genetic predisposition. Some individuals may have a genetic predisposition to elevated ESR. Variations in genes regulating inflammation and immune response may result in consistently higher levels of ESR without any evident clinical condition. 5. Subclinical cardiovascular disease. Atherosclerosis and cardiovascular risk. Chronic low-grade inflammation, reflected by persistently elevated ESR, could be a marker of subclinical atherosclerosis or cardiovascular disease. Studies have shown that elevated ESR is associated with increased cardiovascular risk, even in the absence of traditional risk factors. Therefore, in such cases, it may warrant a more detailed cardiovascular assessment. 6. Infections. Undiagnosed chronic infections. Some chronic infections, such as latent tuberculosis, chronic hepatitis, or low-grade bacterial infections, may not cause obvious symptoms, but could still contribute to persistent inflammation and elevated ESR. 7. Endocrine or hormonal conditions. Mild thyroid dysfunction. Subclinical hypothyroidism or other subtle hormonal imbalances could contribute to a persistent rise in ESR. While not overtly inflammatory, these conditions can subtly affect various metabolic and inflammatory pathways. Menopause or hormonal changes. Hormonal fluctuations, particularly during menopause, may influence ESR levels. Estrogen levels, in particular, have been linked to changes in inflammatory markers. 8. Psychological stress. Chronic stress and depression. Chronic psychological stress or untreated depression can lead to systemic changes that promote inflammation. Elevated ESR has been observed in individuals under chronic stress, even when other inflammatory markers are normal. Chronic stress is known to have a pro-inflammatory effect on the body. Clinical approach, reevaluation and monitoring. In cases of persistently elevated ESR with no apparent cause, a period of observation with regular follow-up might be appropriate. This could involve monitoring for any emerging symptoms, changes in other laboratory values, or the development of new clinical signs. Patient reassurance. If no underlying disease is identified and the patient remains asymptomatic, the elevated ESR may not require specific treatment. In such cases, it's important to reassure the patient and avoid unnecessary interventions. Consideration of cardiovascular risk. Given the association between elevated ESR and cardiovascular disease, a more in-depth cardiovascular risk assessment, e.g., lipid profile, blood pressure monitoring, may be warranted, especially in individuals with other risk factors for cardiovascular disease. In summary, persistently elevated ESR without any clear underlying pathology may not necessarily indicate a serious condition. However, it can sometimes reflect chronic low-grade inflammation, lifestyle factors, or subclinical disease processes that warrant attention. Monitoring, lifestyle modification, and a comprehensive cardiovascular assessment may be useful in these patients.